Great.
Sorry.
So, no problem. So I'll talk very briefly about heart failure. I'm not a heart failure specialist, and as you know, heart failure is a subspecialty within the cardiology, so it's a big deal. We cannot cover this one in one lecture, and I will just talk briefly about some basic concepts that I feel they are important and they are relevant to your practice. But it will not be a hard a rock star talk, so it's going to be very basic, might be boring, but if there is any question either during this presentation or after this presentation, you just feel free to contact me. Again, this topic cannot be addressed in one lectures. It's a 1-year fellowship. After general cardiology, a lot of people, they do advanced heart failure fellowship, so it's 1 year of training. It cannot be just lumped together in 45 minutes or 1 hour lectures, but I'll try to talk about very important concepts that I feel are important to you guys. And those will be the outline. I'll talk briefly about what is heart failure, what does mean heart failure, and we'll touch base on a lot of epidemiological fact. Then I'll talk about history and physical, not in the term that you guys used to know about the history and physical. Then I'll have one slide about the management. I'm not here to teach you how to manage heart failure. It's a very complex topic. I know most of you would know the general guidelines, and that's the expectation. You know the general guidelines or the outlines for treatment of heart failure, but you will need, if you diagnose somebody with heart failure, you need to send them to a cardiologist. Of course, you can start them on the outline therapies, then you can, then you need to send them to a specialist to take care of them. And as you know, heart failure is a complex clinical syndrome. Those are the American, European, and the Canadian definitions for the heart failure. Basically, they are all the same. You can read those. I'm sure you know them, you studied them, and some of them may have memorized the definition of heart failure, but the bottom line, it's a clinical syndrome. It's not an etiologic diagnosis. It's a syndrome that is composed of physical signs, symptoms and physical signs. Then you do some testing to diagnose somebody with heart failure. But it's a complex clinical syndrome that results from any structural or functional impairment of ventricular filling or rejection of the blood. And that's important. If you have somebody with symptoms and signs of heart failure, and if he did an echocardiogram, oh, you said, well, his ejection fraction is normal, he doesn't have heart failure. That's not correct. As you know, heart failure can be systolic, which is related to reduced ejection fraction, can be diastolic, which means that the LV ejection fraction is completely normal, but there is a problem in the ventricular filling. And we'll touch base by the end about that. I have one slide about the pressure volume loop, which I feel it's extremely important that you guys, I don't know how many of you student, I don't know how many of you are resident or general practitioner, I don't know how many of you are on postgraduate training, but no matter where are you standing at the curve right now, you need to know really about the pressure volume loop, and I'll provide you with some resources. That's again, the pressure volume loop by itself, it may need one day to discuss about it, but those are very basic concepts that I feel you guys need to understand them, that will help you down the road in your life. Even if you want to prescribe medications for somebody with heart failure, it's extremely important to realize what is this patient standing on the pressure volume loop. So the bottom line from this slide, it's a clinical syndrome. And that's the European definitions, or I wouldn't say the European classification, but that's the European criteria. This classification is very well known. We have 3 types or 3 subtypes of heart failure, which is the classic one, heart failure with reduced ejection fraction, where the LV systolic function is less than 40%. And now there is a relatively new entity of heart failure with mid-range ejection fraction, whereas the LV systolic function is from 40 to 49. And they call it mid-range because most of the landmark study that we have about, especially about the management of heart failure, are those related to the heart failure with ejection fraction less than 40%. And we have the heart failure with preserved ejection fraction, where the LV systolic function more than 50%. And unfortunately, we talk a lot about the LV systolic function, and we kind of tend to forget about the RV function, which is extremely important. In the past, they used to call it the neglected ventricle or the neglected chamber, but I don't think it's true anymore. There is a lot of recognition for the role of the RV or right ventricular function of the heart, and it's as extremely important as the LV function, the RV function. I have a question, and feel free to participate in the chat. So if you have somebody, let's say 25-year-old female patient, history of rheumatic fever in the childhood, presented with shortness of breath, plus 2 lower extremity edema, JVBs, 12 centimeter water, and bilateral rare, and first sound is accentuated, and you have heard rumbling diastolic murmur at the apex. So what is your diagnosis here?
What is your diagnosis?
I'm not sure if I can see the chat. All right. Somebody said mitral valve prolapse. You are very close, but no, it's not mitral valve prolapse. I said yes, it's a mitral stenosis. So if you did an echo, the echo showed severe mitral valve stenosis with normal LV systolic function. What type of heart failure is this? Ejection fraction is normal. It's 60%. Some said diastolic heart failure, sort of correct. Some said heart failure with preserved ejection fraction. And I think the correct terminology is heart failure with preserved ejection fraction. From the data I give you, there's nothing here to indicate LV diastolic dysfunction. It could well be there's an evidence of LV diastolic dysfunction, but sometimes we use the term heart failure with preserved ejection fraction and interchangeably with the term heart failure, diastolic heart failure, but they are not truly the same. You might have heart failure with preserved ejection fraction completely related to mitral stenosis, which is, we call it left-sided heart failure sometimes, which is very true. Do you guys have a problem with the voice? Do you hear me? All right, great. So the European criteria also require, if you have somebody with heart failure and mid-range ejection fraction or normal LV systolic function, they would require more other testing, like an elevated brain natriuretic peptide to have the diagnosis of heart failure. It's not a big deal. You don't really need to know or to worry about it. But that's something, if you want to know, that the European guidelines require more testing if the LV function is more than 40%, beside the history and physical exam. And this is in my mind, this is an important concept also. This paper just, I think, published 6 months ago in the European Heart Journal, and they talk about the etiology and outcomes of severe right ventricular dysfunction. And you may know this, but it's important to know there is a difference between heart failure and LV systolic dysfunction or RV systolic dysfunction. You may have an LV ejection fraction of 35% or 40%, and the patient is not in heart failure. So again, heart failure is a syndrome. Heart failure is a clinical diagnosis. Those are extremely important concepts. You just need to carry out them through the rest of your career. You just need to know heart failure is a clinical diagnosis. No matter what the echo showed you, if the patient is clinically not in heart failure, they are not in heart failure. You can call them mitral stenosis, you can call them LV dysfunction, you can call them RV dysfunction, you can call them whatever. By the end, they will develop symptoms, or they may not just show you your symptoms because you may not be asked them in depth about their symptoms, or they may not have symptoms at rest, but they may become symptomatic during exercise. And that's an important slide in my opinion. Those are patients with severe RV dysfunction. The majority of them, they are related to the left-sided heart disease. No matter what are the left-sided heart disease. It could be cardiomyopathy with severe LV systolic dysfunction. It could be mitral stenosis. It could be mitral regurgitation. It could be pulmonary vein stenosis. It could be severe aortic valve stenosis, no matter, but the majority of them are related to left-sided heart disease. Some of them, they are related to lung disease and hypoxemia, maybe quarter of them. And you see down from the Kaplan-Meier curve that the mortality or the survival of those patients with severe RV dysfunction somehow is related to the etiology. Lung disease, RV dysfunction related to the lung disease, they carry the worst prognosis here. As you see in the Kaplan-Meier curve, the red curve here, lung disease and hypoxia, they carry the worst survival. Some of them, it's related to the pulmonary thromboembolic disease, some related to the pulmonary arterial hypertension. And I feel sometime you guys, I'm not sure for how long you'll keep doing these lectures, but you may need also lecture about pulmonary hypertension because it's very common. It might be underdiagnosed in your area, but can you guys mute the mic, please? I really cannot talk and somebody's talking. So why do we talk about the heart failure? It's a big problem everywhere. It's a global pandemic affecting 26 million people worldwide, and it's increasing. Like here in the United States, it's an estimated about 6.2 million Americans above the age of 20 have heart failure between 2013 and 2016, compared with 5.7 million between 2009 and 2012. The estimated healthcare expenditures for heart failure, just for the heart failure, is huge here in the United States. $31 billion, equivalent to more than 10% of the total health expenditures for the cardiovascular disease in the United States are just allocated for heart failure. And this is an important graph that will show you that unfortunately the prevalence and the incidence of heart failure is just keep rising. By the year of 2040, we will have close to 1 million new cases of heart failure in comparison to 1960. You see the difference between 16,000, I think, might be more than that, and almost close to 1 million. Almost close to 1 million by the year 2040. That's a projection. All All right, so how does the world is doing? Spending dollar on the health. If you see your area is, unfortunately, they spend $0 to $69 per capita for health, which is one of the major problems that you guys are having. And you will keep having down the road as long as there is no stability in the country, unfortunately, as long as there is no attention to the public health programs as well as to the policy. So there's not much of spending on the health. All right, what are the causes of death in your area? And this is a data from the Institute of Health Metrics and Evaluation. See, ischemic heart disease in the year 2007 was #1 cause of death in your area. This is specifically related to your area. And remained the same in the year 2017, but has increased by about 35 to 40%. Neonatal disease, #2. Unfortunately, conflict and war has jumped to #3 in the year 2017 from being number 100. So those are an important data you need to know about them. If you have a very big burden of ischemic heart disease, you will expect you will see a lot of heart failure patients, which I show you down the road. Again, that's an important graph from the Institute of Health Metrics and Evaluation at the University of Washington. And this is specifically related to your area. What are the risk factors attributing to the causes of death at your place? So we say the causes of death, the most common cause of death in your area is ischemic heart disease. What are the attributable risk factors? If you see in the graph down the pink color, the risk factors are behavioral and metabolic. Sometimes you cannot control the metabolic, but you certainly can control the behavioral factors. So it's an important message for you guys, like physicians and allied health professionals, that you need also, I know it's extremely difficult, sometimes hard to do this, but you need to share your role. You need to educate the public about changing their behavior, which might be extremely difficult to change somebody's behavior, but you just need to talk to them. If you have somebody who is smoking, came to the hospital, came to the clinic, you got to talk to him about he has to stop smoking. Doesn't mean that he would listen to you or he will quit smoking next day, but you have to ring the bell. You have to start this message. It's important. The risk factors are extremely important. Otherwise, there will be a lot of problem in the country. I'm talking about health-related problem. So again, here's the global distribution of cardiovascular mortality rates in female. One of the highest in the world. See, you see the red color? Very high female mortality related to cardiovascular disease in comparison to the surrounding area. Tobacco among male, see your area is, yes, whoever is asking in the chat if it's related to the country, yes, it's this data related to the country. If you see the map, smoking, you guys are outstanding there in the smoking. You have a lot of smoker. This is male smoker, and I'll show you the figure for the female smoker. Female smoker, definitely outstanding, more than anyone else in the country. See, you may have a sort of openness in this. Some other countries, they may not, but I'm not sure. You guys are sharing the same culture with the surrounding area. So I'm not sure if there is a bias there or not. But a lot of smoker, male smoker, a lot of female smoker. And that will translate down the road into a health problem for sure. Yes, our topic is related to heart failure, but if you have a lot of smoker, that will translate to more coronary artery disease and will translate into more heart failure. Again, how much of you guys consume fruits and vegetables? This is the graph. You are outstanding, red color, not good at all. You are an agricultural country, and unfortunately, you are not consuming fruit and vegetables. I was really surprised that a burger cafeteria في عتك. That's interesting to me. You guys are eating, I'm not talking specifically about you, but unfortunately unhealthy diet that would be translated into much of obesity, and the consequences of it is more of coronary artery disease and more of heart failure. What about days lost due to disability? Outstanding in the country. Red color, a lot of premature death. And I'll show you, I'll come to the data about the heart failure. What about coronary artery disease? Unfortunately, the country is ranked number 3 in the world by the age-adjusted cardiovascular coronary mortality related to coronary artery disease. That's huge. In the wrong direction, of course. All right, this is a summary study that was published by Dr. Shemeri from King Khalid University. It just shows you what are the percentage of people with heart failure, preserved ejection fraction, and heart failure with reduced ejection fraction in your country. 30% with preserved ejection fraction, about close to 70% with reduced ejection fraction. And that's another study that I came across last night from Dr. Bahaj, I think from Al-Mukalla, and it just studied the clinical characteristic and inpatient mortality among 100 patients with heart failure, admitted to Avicenna Hospital. So ischemic heart disease is standing number 1 in the etiology of heart failure. Those are important statistical data that very closely related to your practice, and you really need to know them. Arterial hypertension is number 2, idiopathic dilated cardiomyopathy next, valvular heart disease. It surprised me that you have more of idiopathic dilated cardiomyopathy, more of valvular heart disease, but this is very small study, and it may or may not reflect what's going on somewhere else, but those are important. That's what you have, and you need to know them. And that's just the distribution of those 100 patients admitted by the gender. Most of them, they are men. I think 65%, or sorry, yeah, maybe some of them, they are female, but anyway, yeah, 57% male, 59% female. And that's another study from the Gulf Registry or Gulf Care, and I think has been published from multiple, I didn't know about which institutions, but I think, as far as I remember, they said from 8 hospitals in the country. That's important and critical. See, that's the multivariate analysis that identified an hospital predictor of mortality. If you have somebody with heart failure admitted to the hospital, if they are using GOT, like بيخزنوا, they are 5 times more to die in the hospital than somebody who is not using that stimulant. Of course, if they are in a cardiogenic shock, it's obviously they are at high risk of death. If troponin are elevated, if they are intubated. But what strikes me is the CAT user, they have very high risk of death. If they are admitted with heart failure, in hospital death is high. Etiology of heart failure, they just divided it or characterized it by the age. If they are less than 50, if they are more than 50, obviously, if they are less than 50, here from this graph that showed non-ischemic cardiomyopathy is more, but maybe not. I show more figure that ischemic coronary artery disease is maybe prevalent in your area in those age group above 50, unfortunately. Well, CAT is not helpful in the final exam, for sure. CAT is risky. We all study without CAT, so there's no excuse. Whoever is writing in the chat. I disagree, completely disagree. Let's be all on the same page, okay? Completely, I cannot promote this. الشاي الحليب العدني ممكن يكون good for you. Anyway, back to the topic. Quick questions. Who are familiar with the New York Heart Association functional class? Can you write down in the chat how many class or how many grade or how many functional class? Yes. Correct. Correct. 4. Are you guys familiar with those 4 classes? Do you know how to apply them in practice? Good. I'll go over them briefly because they are not as easy as you think. So those are the stage, and I will come to the class. It's important to know the stage. There's a huge difference between type of heart failure, stage of heart failure, and functional class of heart failure. So stage 1, there's only risk factor for heart failure. There's no heart failure risk factor, including hypertension. Stage B, heart disease is present, but there are no symptoms. There are some structural changes before symptoms development. Stage C, there are structural heart disease and symptoms. Stage 4, presence of advanced heart failure with continued heart failure symptoms requiring aggressive medical therapy. Those stages are relatively new, but you really need to know them. You need to act on somebody on stage A and B, maybe to prevent them from going into stage C. Correct. If there is some structural changes, but if there is only coronary artery disease, there might be stage A. If there are some structural changes related to the heart, like the heart muscles or the heart valve, you may call them stage B. But if somebody came into you with just classic angina, they are at risk, they are stage A, because there is not, we don't know on the molecular level, but most of the time, there is not much of structural changes. But if there are original wall motion on the echo, you may call them stage B. Now somebody scribe the screen. Can we remove that? Yeah, sure, thank you. And this is the New York Heart Association functional class. We have class 1, class 2, class 3, class 4. Class 1, patient with cardiac disease, but without resulting in limitation of physical activity. Ordinary physical activity does not cause undue fatigue, palpitation, and so on. Functional class 2, patient with heart disease resulting in slight limitation of physical activity. They are comfortable at rest, but ordinary physical activity results in fatigue, palpitation, dizziness, or anginal pain. Functional class 3, patient with heart disease resulted in marked limitation of physical activity. They are only comfortable at rest. Otherwise, less than ordinary physical activity will cause them to have symptoms. And class 4 is the most severe one of them. We are not yet there. Whoever asking about the dry, wet, cold, warm classification, I even did not put any slide about that. But that classification somehow related to the management. I can tell you about it, but we are not yet there. There are a lot that you guys need to know before moving that far, but you definitely can educate yourself for sure. Yes, there is a classification about dry, wet, cold, warm classification. All right, moving forward to the diagnosis. Most of the time, not most of the time, all the time, heart failure is a clinical diagnosis. But can you diagnose heart failure from only symptoms and signs? You can, but maybe it's not a confirmatory diagnosis without doing more testing to see what's going on. So this study just showed you what is the value of past medical history, including prior use of medication. But most of the time, they will come to you. If they are new, they will not be on any medications. So you need to ask about coronary artery disease. If you have somebody with coronary artery disease that showed to your clinic or to your office or to the emergency department with symptoms and signs of heart failure, the specificity is very high, but the positive predictive value is not that high. And there is a difference between specificity and positive predictive value. We can talk about it at a later time. But anyway, value of physical findings. No, there are many physical findings, but not only one of them will show you. You just need a combination. And it showed here the strongest positive predictive value, maybe from this graph, is somebody with lung rails more extensive. Or no, somebody with a jugular venous distension, hepatomegaly, and lower extremity edema. If you have these three, the positive predictive value that they are having heart failure is 85%, which is very high. So the bottom line, you just need a combination of physical signs, history, physical signs, and down the road the echo. But before the echo, you should have the impression if they have heart failure from your history and clinical exam. And you really need to spend time. I don't know about those folks working in the emergency department, but spending 5 minutes with the patient, no, those are not related to the right-sided heart failure, related to heart failure in general. And the most common cause of right-sided heart failure is left-sided heart failure. And most of the time, from the history and physical exam, you will not be able to tell if this is left-sided heart failure or if this is right-sided heart failure. Unless if somebody acutely came in with MI and acute pulmonary edema, they don't have lower extremity edema, there is no ascites, there is no hepatomegaly, and JPB is normal. So that's likely acute onset extensive anterior MI related to acute LV failure. They might be in extreme situation to the just cardiac shock from acute LV failure. But those are the symptoms that you need to know, the signs that you need to know how to elicit them, because they will help you. They will just move your probability for the diagnosis from being low to high. But you really need training and you need experience, and you need to have a wealth of data, a wealth of knowledge that you need to build up in order to be able to pick up those symptoms as well those signs. The history and physical exam is extremely important, and I'm sure they tell you that in the mid school, but that's a fact. That's a fact. You will see that in your life, either when you will graduate, if you are a medical student, if you are or if you are already graduating. You just need to spend more time of the patient talking to them. There is no limited number of signs. There are many signs that I cannot enumerate because I don't know them all. But the most important physical sign that When you are examining the patient, you look for lower extremity edema, you look for ascites, you look for hepatomegaly, JPB. JPB is extremely important. We may spend 1 hour just talking about the JPB, then you move to the heart, you check the epic speed. Is the epic speed displayed? You may palpate if there is any thrill, then you auscultate the lungs. Those are the classic. Value of symptoms. The most predictive symptoms of heart failure is, of course, shortness of breath. If they have, especially if they have paroxysmal nocturnal dyspnea, or obviously if they came to you with acute pulmonary edema, you think it's likely from a cardiac cause. And this is an important one that I need you to know about it. And I'm more than happy to send the article to whoever interested. This article is in JAMA and about the value of the hepatojugular reflex. It was published in the year 1957. How many of you know how to do the hepatojugular reflex? Framingham criteria are complicated. I don't remember I used them recently. How much pressure do you put on the abdomen? How much do you compress the abdomen? And where in the abdomen? Yes, you compress the liver area. But do you know how much pressure do you exert on the liver in terms of how much of millimeter mercury? All right, good. It is the original paper that was published in JAMA. I think it was published in JAMA. Yeah, very close. Excellent. They say 30 to 40 millimeter mercury, but how do you know you are not at 50 or not at 10? It is just a quick estimation, of course. So put the patient at 30 to 45 degree head inclinations, then put firm pressure on the right upper quadrant for 10 seconds. Some of them, they said maybe up until 1 hour. The normal response, initially you will have a rise in the jugular venous pulsation, but that should come down right away. If it's positive, it will increase, the jugular venous pulsation will increase by more than 3 centimeter water, and that will not come down right away. It would last. Yeah, I will not talk. That's a completely different topic. Somebody is writing can be negative in Budd-Chiari syndrome. Do you know how frequent is the Budd-Chiari syndrome? It's very rare. I don't know the prevalence, so I cannot give you a number. But you guys, as either student or newly graduated, tend to focus on the ZIPRA, what we call the ZIPRA, the rare cases, and that's completely normal. But when you go into the practice, especially if you go to training, you just need to, that's why I'm showing you all of the statistical number, just to make sure to know what's going on in the real life. Those may not be taught to you during the medical school, but those are extremely important. Anyway, I never heard about horses. They are zebra. Anyway, That's an important graph, extremely important, especially when it comes to the management. You really need to know this graph, the pressure volume loop, the second panel in the slide. That is correct. Somebody said when we hear gallop, somebody told them to think about horses. That is correct, but what I'm talking about is completely different topic. Anyway, you need to know, just try to picture it in your mind. You need to know where is your patient standing at the pressure volume loop. And if you really need to know more about the pressure volume loop, I will advise you to go to the cardiovascular physiology concepts. It's there on the website, it's free. You can see all the graph there, and you can see based on the degree of heart failure or based on the type of heart failure, how does the graph looks like. Try to picture it in your mind, especially when you start to prescribing management for those patients. It's extremely important concept. I don't have time, otherwise I would be happy to go over it. If you want, we can talk about it, but that's something you need to know from your physiology, and you need to read about it. It's extremely important to know the pressure volume loop in order to understand how is the afterload reduction works, how is the preload reduction work, and how is the inotropy work. Why would in one patient you will pick an inotropic support rather than going with an afterload reduction? Just 2 slides on the management. Again, the scope from this talk is not to talk about the management or to talk to the management for a cardiologist. And I know that I have an audience from different background. Very few important concepts I would like that you know about it. I would like to emphasize. A lot of patients with acute heart failure, acute and chronic heart failure, they present with the cardiorenal syndrome. So you will see an abnormalities in the kidney function in the acute phase. And that's related to the heart failure due to too many reasons. One of them is the decreased perfusion to the kidney, but most important is the kidney congestion. Is related to the kidney congestions. Among the organ congestions, the kidney as well the liver. And sometimes you will have a profound hypoperfusion that the patient might be just delirious. And you don't know that he is delirious because he has an acute heart failure, severe heart failure. But again, there are more common causes of delirious more than the heart failure, so don't take me wrong. But advanced stage of heart failure, you may see they are delirious among other because of the decreased organ perfusion, specifically to the brain. Sometimes you will be very reluctant of giving diuretic therapy for somebody with borderline low blood pressure and kidney function, maybe creatinine, maybe 3 milligram per deciliter. Well, in fact, the treatment in that specific situation may be the diuretic therapy. We have given, I'm not telling you to, I'm telling you always to ask your specialist, but sometimes we give a massive diuretic doses. And I wouldn't start with a massive diuretic doses, what I mean, but sometimes we give a lot of diuretic and you will be surprised. They will diurese like very well. And then next morning or 2 days down the road, you will see the creatinine going to normal. And in fact, you will see the blood pressure maybe up. If you feel that you have to diurese them and they have borderline low blood pressure, or if you are not comfortable, you can start them on low dose dobutamine. I'm not advocating for any specific treatment here. I'm just talking about the general because every patient is different. And I don't want you to do some stuff and they say, what Aref he said. No, I'm not saying, I'm just talking in general. And there are some landmark study that was published recently. It might be a good idea to have at least a rough estimate about them. One of them, which is very close to me, is the COAP trial. And COAP trial that now the paces, I wouldn't say the paces, but that is of mitral valve percutaneous procedures. And surprising, I wouldn't, maybe not, but the number needed to treat to save one life with the mitral clip is 6 maybe or 7, which is impressively good, better than ACE inhibitor, better than beta blocker for somebody with heart failure and reduced ejection fraction. They are symptomatic if they met the criteria for doing the mitral clip. But the bottom line from this, you may need to know more. It's just not ACE inhibitor, beta blocker, diuretic therapy. Sometime for specifically for people with coronary artery disease, you may need to revascularize them. Valvular heart disease, you may need to replace the aortic valve if they have severe aortic valve stenosis. If they have severe mitral regurgitations, you may need to clip the valve. And those are more advances in the last decade for the treatment of heart failure and valvular heart disease. And if you have seen somebody with heart failure, you try to establish an algorithm for yourself. Like you look to the heart and say, okay, the heart has a pericardium, the heart has an myocardium, the heart has an endocardium. So if this heart failure, always keep a system in your mind. Is this heart failure related to pericardial disease? Is it related to myocardial disease? Is it related to endocardial disease, including the valve? Or it's related to the arteries supplying the heart? Or is it related to the pulmonary arteries and it is just right-sided heart failure? So those are important concepts. You need to know them, I think, and you need to read more about them in order to be able to help your patient. Most importantly, you need to try to influence the people to change their behavior. Ask them to quit smoking. Hypertension, it's very common in your area, and I think it's undertreated or not treated. A lot of people, they don't take their blood pressure medications. So you just need to educate them, and you don't need to prescribe them very fancy medication, expensive medication. Cheap medication would work. Anyway, I think I'm done, and I think I'm done on time. So we have maybe 10 minutes for questions or more. By the way, if you have any questions at any point of time, I'm available. You can text me. You can text me on Facebook. You can text me my cell phone number. You can email me.
Okay, did you finish, Dr. Aref? خلاص? As a lecture, I mean.
Yeah.
Okay, so thank you very much, Dr. Aref, for your kind presentation. It was a very precise and concise and informative. And I really appreciate your efforts and that you managed to give us this lecture, although that you have a busy schedule. So thank you very much, and thanks everyone for your attendance. By now, I will send some question that came to me in private. Okay, if you don't mind, sorry.
Yeah, go ahead.
Okay, so there is question here in regard to the presentation of the heart failure. As I can see from this lecture, there is some overlap between the right and the left heart-sided. Therefore, the classic presentation that we know, for example, orthopnea, dyspnea, and BND in the case of left-sided, and edema, etc., in right-sided can be overlap in both diseases. That's right or not? This is the first question.
That's correct. You wouldn't be able, most of the time, you would not be able to differentiate or type of heart failure without further imaging.
It's not a solely clinical diagnosis for the heart failure.
No,
because
heart failure is a clinical, heart failure syndrome is a clinical diagnosis. But when it comes into the etiology of heart failure, or if you want to confirm your diagnosis, you might need an imaging. But say, for example, if you have somebody that for whatsoever reason they did an echo and his ejection fraction is 35%, does that mean he's in heart failure? Absolutely not. He may have an LV dysfunction only without heart failure. But Heart failure, when you say the term heart failure, it implies presence of symptoms and signs. They may have a history of heart failure, well, that may be treated, and now they are very well compensated. They are not anymore in a heart failure state. But heart failure, it's a clinical diagnosis. No single test in the world will tell you if the patient is in heart failure or not. Now there's a lot of talk about natriuretic peptide. Well, it can be elevated in heart failure and non-heart failure condition. That's a completely different talk.
Okay, thank you. There is another question about the diastolic heart failure. Does it have a worse prognosis in comparison to the systolic?
Maybe, because unfortunately we didn't have treatment for that.
So by the other mean, if you have to choose between heart failure, pray to be a systolic, not the diastolic one.
No, well, we see a lot of right-sided heart failure that is manifested classically with the symptoms, like the symptoms and sign of right-sided heart failure and severe RV dysfunction. And the LV could be completely normal systolic, but there might be an indication of diastolic dysfunction. So no, diastolic dysfunction or diastolic LV-sided failure can result in right-sided heart failure.
Okay, here's also a question about the examination. He said that we in medical school we have been taught the JVB, the large A wave, the canon A wave, the absent A wave, the dicortic notch, etc. Is that has any significance or not, or just just a textbook things, yani?
Well, there's no textbook things and real life things. Sometime when you are getting out of the medical school or out of residency, you may have a difficulty eliciting the symptoms or signs, and that's completely normal. Some of the signs may have been described 100 years ago. They might be still valid. I'm not sure about their value for you as a practitioners. The most important aspect, I wouldn't quote you if you said, well, the A wave, the V wave, the X wave, the Y descent. Those are very well described signs. Yes, they are very difficult to elicit and you need an experience. That's why cardiology fellowship is 3 years. And even after a cardiology fellowship, you will have a lot of people, including myself, having difficulty illustrating, well, this JVB has no A wave, and that's normal. It just needs a lot of training, but at least if you are a resident, or even if you are out of the medical school, you need to know if the JVB is high or not. But those symptoms, they definitely have some value.
Okay, here is a question in regard to the atrial natriuretic peptide and the PNP or the brain natriuretic peptide. Is there any diagnostic value, at least negative predictive value, or at least something to rule out? For example, if we have a negative BNP or ANP, can this exclude the heart failure or not?
No, heart failure remains the diagnosis, is a clinical diagnosis, no single test. Well, if you have a negative brain natriuretic peptide, the likelihood of heart failure is low, but we know for sure, at least from the published literature, that you may have a negative heart failure, like an obesity. You may have a negative brain natriuretic peptide, and the patient may still have heart failure, but it will make it less likely.
Mm-hmm. Okay, here's other question. He says that if the patient has a CTO, I don't know what does he mean by CTO. I think chronic total occlusion or something like that. Can he progress into heart failure, and if he progressed to heart failure, can he get any benefit from BCI or any interventional disease or not? Interventional. I think this is an advanced question. I did not get it actually.
That's very advanced questions. It's a debatable issue, but if you have somebody with LV dysfunction or heart failure and he has a CTO, and you proven by the imaging that he has a viable myocardium and he has large myocardium at risk, if you revascularize them, it may, but there's a lot of other literature that shows there's no survival benefit from the CTO. it's a completely different topic, completely different subject, but it depends. There's no yes or no answer for maybe medicine in general. You will rarely find a clear-cut yes or clear-cut no, unless if you have a clear-cut multiple clinical trials showing no benefits of this particular intervention over the no intervention, maybe.
Here is a question from Dr. Salim. How much the risk for patient with controlled hypertension to develop heart failure?
That's a good question. I cannot give you an estimate, but if the blood pressure is low control, is very well controlled, they have a less chance of progressing into heart failure than somebody who has hypertension that is not well controlled.
Here's a question also from Rami. He say, is there any diagnostic value for causal signs in right ventricular heart failure?
Yes, if you have a positive causal signs, it just tell you there is something wrong either with the RV or with the pericardium, and that you just need to go more and dig and see what's going on.
Here is another question. For cases of ischemic cardiomyopathy, is it by any means can be reversible, specifically for ischemic dilated cardiomyopathy?
It depends. If you have scarred myocardium, end-stage heart failure, well, even if you revascularize them, they may not benefit. But it's a very complex topic. But if you have somebody with hibernating myocardium and moderate to severe aortic dysfunction, if you revascularize them, yes, they may get benefit. So you just need to know what's going on. Are they just ischemic? Are they ischemic and hibernating, or are they scarred? If they are already scarred, I wouldn't be very scientific if I said if they are already scarred, maybe there is no benefit. It depends.
Just doctor, correct me if I'm wrong. By hibernating myocardium, you mean that will improve by improved contractility at rest, and it's reversible when there is an adequate oxygenation, right? By hibernating myocardium.
That's maybe the simplest term. Hibernating معناها نائمة، يعني عايشة كسلانة في سبات شتوي تقريبا. And sometimes you will have hard time differentiating them from non-viable myocardium.
طيب دكتور، هذا السؤال بس مني جاء الآن، يعني ال MPI will we get يعني any benefit اللي هو myocardial perfusion imaging? Should we do it before proceeding into any intervention?
That's another topic. Again, it depends on the presentation. There is no much of a solid general rule. One aspect is fitting every other. So it's not necessary to do the MPI study for every patient before you proceed with the intervention. If you have somebody with acute coronary syndrome, well, you don't need to do the myocardial. If you are in doubt, you may do the myocardial perfusion study, but again, that's completely different topic. But no, the answer is no, but it depends on the clinical presentation and it depends on your patient.
Okay. Here is a question from Dr. Saleh Al-Abed, and I'm really thankful for Dr. Saleh because he's the one who initiated the communication with Dr. Aref. He asked about the use of ACE inhibitors in a patient with heart failure, but the patient has hypotension. So I think that's ACE inhibitors has some therapeutic value. Some trials found that there is some therapeutic value in patient with heart failure. So if the patient has hypotension.
It depends on the hypotension. And it depends on the definition of hypotension. Vasodilator are cornerstone managing heart failure with reduced ejection fraction. If you have somebody in shock state, you don't want to give them this inhibitor. You want to treat them maybe with inotropy till they get better. And sometimes you put them in this CV ICU or the coronary I would call CVICU. You put them on maybe nitroprusside or maybe dobutamine, and only with the nitroprusside and diurese them. Then you start introducing a little bit of captopril till they tolerate it and get out of the acute decompensation. But you don't want to give, a general rule, any hypotension, especially true hypotension symptomatic, don't give them any antihypertensive medication. Some of them, in fact, you may hold the ACE inhibitor and the beta blocker, especially if they are very badly decompensated.
Okay, here is also a question, Doctor. There is many questions. So this, I think, only two remaining. Here is a question. I just want to understand it well before, because it's yeah. Is the dizziness by? I mean, my understanding for the question, I hope from the one who asked me to recorrect me if I'm wrong. Is the severity of dyspnea, or for example, if the patient has orthopnea or BND, is that can classify or stratify the degree or the severity of heart failure or not between the orthopnea and BND?
If you have somebody orthopneic, for sure they are more severe for heart failure. They have paroxysmal nocturnal dyspnea. They are symptomatic. I would consider that maybe they are symptomatic at rest, but they are. I'm not sure if I am talking scientifically now or just talking from my experience. I'm not aware about any study showing the severity from somebody with orthopnea versus somebody with paroxysmal nocturnal dyspnea. That's why I'm saying maybe I'm not talking scientific here. But if somebody with orthopnea, they are definitely they are class 4 heart failure. PND, they are close to there, but they are not yet badly symptomatic all the time.
Here's a question from Hannah. Captopril versus losartan. Which is the best choice?
It depends. If Hannah's asking about my comment, which I said maybe 1 minute ago, that if somebody is badly decompensated, we put them in the CVICU on dobutamine, on diuretic therapy and nitroprusside, then if you start weaning them or start building them up to get them out of the ICU, you start them with the captopril and you start with the very small doses. If somebody is stable, coming to you in the clinic, well, you don't want them to put them on captopril because captopril, they're gonna use it 3 times. You wanna put them on if they have any side effect from ACE inhibitor, you can use it often too.
Okay, here is the final question that I have received. Is there any therapeutic value for digoxin, or just it provides some symptomatic improvement or symptomatic relief?
If the one who posed the question is asking about mortality, well, there's no mortality benefit from digoxin.
Mortality, yeah, mortality.
Risk of hospitalization, it's not popular anymore. I rarely see it here in practice, just for heart failure, but sometime you may still see it.
Mm-hmm. So يعني ما فيش فايدة immortality, there is no benefit, direct benefit from it.
There is no mortality benefit.
Mm-hmm. Okay, so I will ask for the last time if anyone have any question. Okay, here is a question from Dr. Saleh. Digoxin in heart failure with renal impairment. Dr. Saleh, you mean can be used or not, صح?
I would avoid it. We have better alternative. But again, I have really hard time answering specific questions because most of the time it depends on the patient, it depends on the population. And it depends on your patient, but the general role of somebody with heart failure and you are using the digoxin for treatment of heart failure and they have severe aortic dysfunction and they have CKD, you better avoid it. And if you have to avoid it, you just need to be aware that you need to adjust the dose to the kidney function and you need very close monitoring for the toxicity.
Okay. هذا سؤال جالي على الخاص. Okay, for case of heart failure developed arrhythmias, is it better to use antiarrhythmic drug or use pacing or devices therapy?
It depends on the arrhythmia. Pacer and CRT, they have in the term that the CRT, we use them to synchronize the myocardium and they synchronize the contractility. Pacing, we use them for the rhythm if they have bradyarrhythmia. But if somebody with heart failure and ventricular tachycardia, it depends on too many things, but they may need an ICD rather than antiarrhythmic medication. You may use, again, it's another complicated topic. You may use, and I don't know if there is any data supporting use of antiarrhythmic like amiodarone to suppress, but say sometime we have somebody with heart failure, they have an ICD, and they keep coming to the hospital with the ICD shock. At that time, you may use amiodarone to suppress the arrhythmia, just to give them rest from having been shocked with the ICD, but you need to address why they are developing the arrhythmia. Are they decompensated? Is there an ischemia? It's most of the time try to treat what the underlying cause rather than just to prescribe antiarrhythmic. But yes, sometimes we see them on antiarrhythmic medication just to suppress the arrhythmia, but it depends on the type of the arrhythmia.
دكتور احنا classically يعني when we study medical school كان cardiac resynchronization therapy used actually when there is a bundle branch block I think يعني. So I believe it's an individualized therapy يعني to choose between ICD or resynchronization therapy or even medical antiarrhythmic drugs, right?
There is a difference between the ICD and the cardiac resynchronization therapy. They are both, they are used for different now, most of the time, if you would put in CRT, you will put CRTD, because you're already there. And if they have an indication for the CRT, they will definitely, they most of the time have an indication for ICD. So you put CRTD, but the purpose of the cardiac resynchronization therapy, somebody with heart failure, left bundle branch block, and there are some other subtypes, but they are not as clear as left bundle branch block with a QRS duration more than 150 milliseconds.
Okay. Thank you very much, Dr. I finished my question. I really appreciate your attendance and I really appreciate that what you have did for us. If there is any last comment from you, I would appreciate it.
Yeah, you just spend time with your patient, really listen to your patient, study hard, and the sky is the limit.
Thank you very much, Dr. Aref, for